So for our case today, we have a 45-year-old man who presents to urgent care with 2 days of left leg pain. He's just returned from travel to Europe, and he undergoes an ultrasound, which diagnosed an acute left popliteal DVT. He's not taking any meds, and he also tells you that he does shift work and he eats at unpredictable times. On his off days, he also intermittently fasts. So, which of the following DOACs should be avoided for maintenance treatment of his DVT? Is it apixaban, dabigatran, edoxaban, or rivaroxaban? Which one should we not use? All right, so the answer is going to be rivaroxaban. We're going to do a deep dive into the pharmacokinetics of this medication. Rivaroxaban is one of our factor Xa inhibitors. There's 3 main indications where you'll use it. You can prescribe it for VTE prophylaxis after certain ortho surgeries. You can use it for VTE treatment. And then finally, you can prescribe it for stroke prevention and non-valvular atrial fibrillation. For these last 2 indications, which use the higher 15 and 20 milligram doses, you have to take it with food, and we're going to go over why that is. So based on early trial data, the bioavailability for rivaroxaban was determined to be excellent for all 3 of these doses when you take it with food. But for the 15 and 20 milligram doses, their bioavailability drops dramatically when you take the medication on an empty stomach. For example, for the 20 milligram dose, its bioavailability can drop as much as 34% when the patient's fasting. So in order for these doses to be effective, they have to be given with food in order to get adequate drug levels. Because the labeling for use in AFib specifically mentions taking rivaroxaban with dinner, some have wondered whether this timing really makes a difference in how well the drug is absorbed. And the short answer to that is that it doesn't. But if we're going to dive a little deeper, a group of authors tried to answer this question in a clever way, where they looked at pharmacokinetic data from 2 existing trials studying this drug. One was studying it in DVT treatment, and this was the Einstein DVT trial. And then the other one looked at it for stroke prevention in AFib, and this was Rocket AF. The patients in these 2 trials were fairly similar in demographics, and one of the main differences besides the study question was which meal people took their dose with. In Einstein, people would take their dose with breakfast, whereas in Rocket AF, they would take it at dinner time. And as a very big oversimplification of what happened in the study, the authors performed what they called a cross-study analysis, where they tried to see how well a data model created from the DVT group could predict the pharmacokinetic outcomes in the AFib group and vice versa. And based on this analysis, the timing of the meal, whether it was dinner or breakfast, it didn't really impact the drug bioavailability. So if your patient prefers to take their rivaroxaban in the morning instead of at night, as long as they're taking it with food, it should be fine. Another important thing to note is the absorption of rivaroxaban mainly happens in the stomach, with decreased drug absorption once it gets to the small intestines. And so because of this, an important takeaway is that if gastric absorption of medications is impacted, like if your patient is status post-bariatric surgery or has a post-pyloric feeding tube, you should be wary about using rivaroxaban or actually any of the other DOACs for that matter, because similar concerns exist. So in summary, when prescribing rivaroxaban for either of these indications, make sure your patient can reliably take it with food, or else you'll run into trouble with low drug levels. And the good news is that the timing of when this med is taken with food doesn't matter. And finally, use caution with DOACs if you have a patient with gastric absorption impairment. You should instead consider using something like warfarin or a heparin agent instead. Any questions?